Anyway, welcome to the podcast. This was season 2, episode 2. It's great to have the absolute legend, Giles Gyer here from OMT Training. Thank you for being here. Absolute.
Well done.
He is a legend. I'm a little bit of a fan, I must say. Before I was talking to him off air, I have his book. I've read his research. In fact, my thesis on spinal manipulation was heavily influenced by a lot of stuff that you've done. Then I'll also introduce my co-host. Many people call him the Tony Stark of chiropractic. I call him Redmond, but his name is Stephen Redman. Introducing Dr. Stephen Redman.
Happy to be here. Thank you for being here, Giles.
Hopefully you're happy
How
to
you
be
doing,
here.
buddy? Nice to meet you. Yeah, man. Yeah, the Tony Stark. I was getting more sort of Boogie Nights, 1980s porn star, but I think both genres work pretty well.
I mean, isn't that what Tony Stark looks like anyway?
Basically, yeah. It's a very good look, man. I'm jealous.
That is his vibe, isn't it? Like he kind of just he encompasses the entirety of that vibe. I'm really happy to have you on. Thank you for being here. Well, I've got a bunch of questions that I'm looking forward to getting into. But first, what I'm going to do is I'm just going to read out a little bit about you so that people that are listening, our audience, has a bit of an idea of who you are. Giles is a musculoskeletal specialist with over 15 years experience in manual therapy. He graduated from the College of Osteopaths in London before moving into clinical practice and lecturing, writing, and researching. Giles is seen as an international expert in HVLA, high velocity, low amplitude, and mobilization techniques, having written 4 books on osteopathic and chiropractic techniques and numerous published research journals on the topic of manual therapy. Having lectured in over 45 countries worldwide and worked with multiple professional sports teams, including professional football and the NBA, etc., Giles' approach to treating and teaching is an evidence-based approach looking at the combination of education, exercise, and manual therapy for the individual. What I want to know is, how did you get into osteopathy? And then also, more specifically, what is OMT for the listeners? And also, how we can find your courses and how we can get more involved with that.
Right, so I'll answer your question. So how did I become an osteopath? When I was in my early 20s, I was heavily into weight training and bodybuilding, and ended up injuring my lower back training very badly with a lot of ego. And I saw osteos, physios, chiros. I saw everyone and didn't get the results I wanted. And it wasn't until I met an osteopath who basically his whole goal was to try to get me back into the gym as fast as possible that I was inspired to become an osteopath. And so that's how I literally slipped into that profession. And then in England, it's a 5-year degree, part-time, and that allowed me to still work doing my other job at the time and study at the same time. So if I'd have met a chiro that had been that sport specific, I'd probably be a chiropractor by now. Or if I'd been a physio, I'd probably, be a physio. But for me, I lucked and went and met a decent osteo, and yeah.
Before we carry on a little bit more, can you give us a little bit of an insight of some of these professional footy teams and NBA? I didn't read them all out, but when I was kind of researching you've helped some pretty high level teams. What was that like?
Yeah, we've been quite lucky. So we've worked with like Liverpool, Manchester City, Arsenal, Crystal Palace, Southampton. We've worked with the Memphis Grizzlies, the Oklahoma Thunders. We've worked with quite a lot of professional teams. It's a really interesting environment to work in. Professional sport and real clinical practice are 2 very, very different things. And working in those environments are incredibly challenging because, those sort of athletes, they tend to get a lot of treatment, sometimes when it's not needed. If you don't do the technique, they'll find someone else that will. So it's a real balance. And there's a lot of ego in there as well. It's an amazing experience, but the therapists, man, they work so hard.
Yep.
And they don't get paid enough for their job. They really don't. Those guys are working 7 days a week, 24 hours a day. And, they're working a lot, very, very hard, for the love of it, really. But it's a good experience. Each sport has its different challenges. Each sport has sort of different types of injuries, different facilities, different recovery processes. So yeah, it's an interesting process. It really is. It's not an environment I'd like to work in full time. I quite like dipping in and out, but it's a very challenging place to work, professional sport.
You often see on these live sporting events, especially the NBA, sometimes you'll see the chiropractor or the osteopath on the side of the field administering their high velocity thrusts. Have you had any stories like that?
I've seen it. I've seen it done badly as well.
Oh no!
I think there's one with Andy Murray getting a really bad thoracic manipulation mid-court. Whether it's needed or not at that time, there's a balance there. I'm not a massive fan, to be honest, of like halfway through a sporting event to start cracking the crap out of someone. But again, it's very dependable, because obviously when you're talking about those levels of athletes, sometimes what they want is what they get, whether you think it's ethical or not, or whether you think it's realistic or not. If you don't do it, they will replace you and find someone who will. So it's a real delicate balance, to be honest.
And obviously they have a large team, right? They have like strength coaches and sports scientists and physios and rehab and they have money and they have options, don't they, at the higher level?
Yeah, they do. I mean, the teams are not as massive as you think, though. Like in some of the professional sports teams, actually you may only have sort of 4 or 5 physical therapists, or for whatever terminology you want, treating the team. They'll then have maybe some massage therapists or soft tissue people coming in. They might have an osteo or a chiro coming in on an ad hoc basis, but it's not massive. They'll probably have a doctor on staff. Yeah. When I worked with one of the NBA teams over in the States, they didn't actually have a doctor on staff. They actually would have to take the team to the local hospital. So actually they had a very small team.
Oh, wow. And that was NBA?
They had like 5 people. Yeah, that was one of the NBA guys. Yeah.
Oh, that's really interesting.
Yeah, it was interesting. Very interesting. But yeah, so the last team I worked at was the Oklahoma Thunders. They had a wonderful facility and a really nice team. They had sort of athletic trainers. They had some physiotherapists there, sports scientists. They had a really nice S&C section as well. So it's really nice to see how they were training the players as well during their rehab. So it was a really good process to see.
It's really cool to see these different careers, like sports scientists, exercise physiologists, even athletic trainers, just continue to grow and become more and more popular, more and more common. I feel like a decade ago, you'd be hard pressed to hear about this stuff. Now they're more and more becoming an option in the industry. So you've got more people going to study and graduating through these roles. What are your thoughts in general across the board with physiotherapists, chiropractors, I suppose massage therapists? I mean, being where you are and having as many connections as you do you refer out to any other manual medicine type person? If you do, why? And if not, I suppose why?
Oh man, I refer all the time. Mate, teamwork is the dream work. As cliched as it is, I'll be honest, I am really fucking good at treating generalized MSK stuff between the age of 18 and 80, right? Yep. You come to me with general MSK stuff and I'm pretty much bang on the money. If it's outside of that, I won't treat children because I believe treating children is a specialty, right? I did a 5-year master's and then, 5-year degree. And then after that, you can do a 2-year master's in pediatrics. So for me, that's a specialty, right? So I refer out. I won't treat pregnant patients because again it's a specialty, and I believe that you should be good at your scope. You should understand where your limit stops. And I will refer. I've got some colleagues of mine that are fantastic physios that specialize in pregnancy. I've got fantastic colleagues of mine that specialize in post-operative rehab, in all sorts of stuff that is outside of my scope, because for me it's about the patient. I want to give the patient best care, and if I can't facilitate that, it's my duty to allow them to go and see someone who can give them the help that they need. If you believe that you can treat everything and everyone for everything, you just cannot. You can't. I understand why people don't. There's a monetary thing there. You refer to someone else, there's a fear the patient isn't going to come back, and then you're losing some income. But ultimately, we as clinicians, our job is to help the patient. It's about the patient, right? The treatment is about the patient. And so therefore I'm a massive fan. I only have a 30-minute treatment window, right? Which means I can't, and I'm not an S&C coach, right? So I'm not, as much as I've got qualifications in training and that sort of aspect, if I think my patient needs to go into a rehab setting and that's going to be better for them, I've got strength coaches I work with, I've got movement guys I work with, and ultimately what the patient does off the table is far more important than what we do on it. So I'm a massive fan of getting the patient in with other professionals. Because it's just best practice. Don't be afraid to refer. People are afraid to refer to other specialties or specialists, and it's nothing to be worried about, man. I really do think you really are. Teamwork is the dream work. As cliched as it sounds, you have to refer out when you don't know.
Yeah, and I've heard you say some of this before. So for our listeners, when I was at Chiro school, I would come home and I would spend the weekends or the nights doing a lot of the OMT courses. A few of the ones that I really enjoyed that are extremely comprehensive, some of the best online education I've ever seen. The dry needling course, I did the diploma, the osteopathic technique I did. I've done some of the red flag stuff you have on there, the cupping, myofascial decompression.
All free, man. There's some free stuff too.
Yeah, there's a lot of free stuff, and at the end of it, if you want the certificate, you can pay to have that certification, and you can have the nice little.
You pay like £10, man, for a certificate. You pay peanuts.
These courses are so comprehensive, and even the more expensive ones, which aren't expensive, like the dry needling diploma, are so comprehensive. And I'll bring this in right here just for a second. Advanced osteopathic and chiropractic techniques for manual therapists. And so pretty much your osteopathic and chiropractic technique course is based, I mean, it's one and the same. They're very similar, right?
That online manipulation course is based on our two books. I think we stopped at around about 170 techniques on that, just because it got too expensive to film.
It is mind-boggling.
Yeah. I mean, clinic. We were in the studio, and Jimmy was like, "Giles, stop filming technique because we can't afford it."
I would spend an extended period of time going through. I would put them into a document. I would practice. I'd come back to it. Practice. Come back to it. And man, I got to the point where I got to the extremities, all the kind of foot-based adjustments, and I was just like, holy.
I'm going to stop you there, right? I'm going to stop you there. Anyone can crack the neck, right? Anyone can crack the back. Good extremity manipulation. Now that's a freaking art form. And we're publishing a book next month. It gets published on foot and ankle technique.
I love it.
And we co-wrote it with an orthopedic foot and ankle surgeon. Because I got really weirdly obsessed with foot manipulation, not like in a creepy way.
No, you're great at it. You're so good at it.
I really like foot techniques. It's really effective.
I've never seen anyone adjust feet like you. I must say, on YouTube, I would go through your shorts because you have those YouTube shorts. That
sounds really creepy. You're a big man.
Lucky you put your trousers on before this.
I'm going to make your size. You can do whatever you want.
I'm lucky. Yeah. No, I was flicking through all the YouTube videos, 60-second ones, and you're like, okay, we're going to do, a cuboid, cuneiform, talus, calcaneus. We're going to do this type of vector on the calcaneus. I'm just like, man, this is just some insane stuff. And I got to the point where I got really good at like a midfoot adjustment, really good at like a talus, a calcaneus, maybe 3 or 4 adjustments. And that's probably where my skill is at the moment, if I have to be honest. Stephen's clearly a lot better than I am at manipulation. But I just got to the point where I had, 3 or 4 ones that I could confidently and competently do. But man, there were just so many options. So, that's pretty cool. You were talking about specificity and referring on. This is a very interesting conversation, one that me and Stephen often talk about. I had a friend tell me yesterday, this is a relevant story. He was in clinic and he got his patient better in clinic as a student within 3 visits. And then the mentor pulled him aside and effectively told him off because they said you need to have them in for at least 6 weeks so that you get to explain the philosophy to them and you can keep them on as a wellness patient. So you can keep them on forever. So he's like, if you get them better too quick, then you can't explain what chiropractic is about and you can't get them coming back. They'll just move on, right? They'll come back when they're injured, but that could be a patient that you could have every month, every week, every fortnight on the fortnight for the rest of their life. What would be your commentary on that story?
Personally, I have a lot of issue with that. I think it's probably an unethical way of looking at treatment. It's not something that I was ever trained in. So we were never trained in repeat treatment. Okay, so for us as osteos, it was on average 4 to 6 appointments for most general things. Would be a good time frame. As long as they're doing rehab and exercise. Chronic things take a little bit longer, sometimes trauma and acute things take a little bit longer. But the idea for me to see a patient, if I'm seeing that patient, right, 3 months every week and I'm seeing them 12 weeks later, I've probably misdiagnosed it. I've probably got the wrong concept. I'm probably not looking at it properly. I'm not a massive fan of the idea of multiple treatments, multiple appointments, repetitive, ongoing treatment plans. I just can't. There's no good research around it. It's not my philosophy. It's not my teaching, and it's not something I would ever do in clinical practice. It's not something I teach. For me, once the patient is in a good place, my goal is not to see the patient. Right. I'll be honest. My goal is not to see them. My goal is to give them the skills that they can cope and deal with stuff themselves. Right. Because, you know, if I have a patient that's constantly relying on me, that is not treatment. That's like an addiction. I want the patient to be self-efficacy. I want self-treatment. I want them to be training, exercising, educating. I'm not going to bother telling them the fucking philosophy of AT still. I want to tell them how to eat properly and how to go to the gym. Yeah, no, I've got a lot of problems with that. And I see this in the industry. I appreciate there's a financial element to this.
Yes.
And when you get to a certain level in your career and you are financially stable enough, then you can have ethics. And it's very comfortable when you're a new grad to go, oh no, I will see you every week, 3 times a week forever, because I need the money, I need to pay my bills. So I do understand it.
Yeah, and throwing to you, Dr. Stephen, would you want to comment on that story?
Yeah, that's definitely a kooky philosophy, money-oriented thing. I know here in the US, it's really big for these practice management groups that have infiltrated the chiropractic profession. And they tell, like, they have a slightly different story for every, like, the business. Like, they just have a different why. But it ultimately always comes down to these long-term treatment plans. A lot of them require upfront payments of $2,000 to $5,000, and then they'll dissuade their patient from even wanting to pursue using their insurance because they know the insurance is going to cover it because it's not medically necessary. That should be the biggest red flag right there. That it's not medically necessary for you to pay $5,000 to see a chiropractor. Which you probably don't. If you do, you're seeing the wrong person. You shouldn't be seeing the chiropractor.
Listen, I was going to say, if you're having to get a fucking a bank loan, or you're having to go for a payment plan for physical therapy, oh come on, man! There's issues. There's massive issues. It really is.
Yep, big time. And one of the interesting things we often talk about on this podcast is Stephen being a chiropractor will often get people walk through his doors, seeing him as a chiropractor, telling him stories about the last chiropractor they've seen. Sometimes they're good, but hey, Stephen, sometimes they're not.
Yeah, I recently just had a new patient, and they clicked on this thing on Facebook and they signed up for like this, I think it was like a $45 consultation with the chiropractor, and the chiropractor did like an exam, and they gave him a discount on x-rays. They didn't charge him for the x-rays or anything like that. I was like, no, that's because they were going to charge you for that in that $3,000 payment plan thing. They're like, yeah, that makes sense.
I mean, you get good and bad in all professions, right? You get good physios, you get bad ones. You get good chiros, you get bad ones. You get good osteopaths. No, we're all good osteopaths. No, you get good ones, and you get some really... you get some good ones.
I think we know about that.
And you get some really good ones. And that's the same across all professions. And you know, you're always going to have that balance between good ones and bad ones, and it's really difficult because sometimes the bad ones have got better marketing, and they do. I feel really sorry. They sometimes do, man. Marketing's king. Yeah. It's a real difficult. I feel sorry for the patients because I've had patients come to me, and they'll have said, "Oh, I've seen an osteo. I saw him for 5 years. I saw him once a week for years for my headache. Do you still have a headache?" "Yes." And I'm like, "Come on, man." And then they're expecting a miracle cure in one treatment, and I'm like, it doesn't work like that. It can be very, very challenging. And that's one of the things in our industry is there's a big financial drive to it. There is a tendency, and it's very difficult. It's a really difficult process.
Yeah, one of the things that we were taught very strongly when it came to communicating with patients was to really kind of shoehorn in the philosophy of chiropractic, because what it would do is it would justify the clinical intervention, and it would also justify how often you're seeing them. I found this to be extremely unethical. The idea would be, we were being forced and told and strongly encouraged to talk a certain way, to say certain things, so that our patients that were seeing us understood, hey, I need to come back. I need to come back. I need to come back constantly. And we'd often do it through this thing called the 3 T's, which would often be a way to explain how someone gets subluxated or how their bones go out of alignment. It'd be thoughts, trauma, and toxins. Now, in terms of those things actually being legitimate things that can cause problems, that may be true, but it would be used in a way to say to the person, I'm going to adjust you today and I'm going to make you feel better. I'm going to restore nerve flow. I'm going to restore innate intelligence, but you're going to require this again and again and again and again. And the reality of that philosophy is it's a cycle that never ends. There's never an off-ramp. There's never an off-ramp into rehab, an off-ramp into something else. I find that to be extremely unethical. And I think that's why out of all the professions, chiropractic tends to have a lot of people doing this same model. But then on the flip side, there are these progressive chiros, especially with MPI and various other people around, and they're absolutely killing it, man. Like, they're stuff fantastic. They're really, really awesome practitioners and clinicians. But it's just that struggle between this kind of clinical and philosophical mindset when it comes to traditional chiropractic. And I think that's just bringing some context to what we were talking about before. That's the why. I think these people, either they know they're being dishonest or they're so caught up in the philosophy of it, they truly believe that having you come see them every week for the rest of their life is actually important, because it's not a musculoskeletal thing. It's a universal and innate intelligence thing. It's all this philosophical stuff. Does that kind of make sense?
Yeah, it does make sense. Bear in mind, that sort of stuff doesn't tend to happen now in the UK. It's very rare that you'll get chiropractors. I mean, if you know, the books that we've written have all been collaborative with chiropractors, and we work with chiros. Some really fantastic ones. But I have seen, especially on social media and YouTube and stuff, you'll see a lot of very high profile chiropractors with this sort of almost this vitalistic concept. We've done some lectures for some of the chiro universities in the States when lockdown happened, and talking to those students, there is almost this innate philosophical process that they go through. But remember, you're talking about a philosophy that was over 100 years old, man. Like Palmer and Still were these Midwestern shit kickers that were out in the, and we're talking about a concept that is, I mean, I love osteopathy. I like the philosophy, but is it relevant in 2023, right? I like, chiro. I like the concepts and some of the philosophy. Is it relevant in 2023? It's nice to have an idea of where we came from, but can we sit there and justify some of the thought processes that were around hundreds of years ago in modern society, with all of the research we have, with all of the concepts we have, with all the access to information that we have? Can we really still hold on to those sort of paradigms when I think some chiros and osteos, their whole virtue, their belief, their personality, everything who they are is built up around this idea. And to challenge that and to change their thought process is almost like changing who they are as a person. And it's that can be a big, big thing for a lot of guys, which is why they hold on to the philosophy. Osteopathy is one of the most disjointed professions I've ever worked in, with weird concepts and pseudoscience intermixed with scientific thought process. It's a really interesting bubbling mix. And some osteos are so ingrained in this historical philosophy that if you said, actually, there's no research ever been published to validate what you're saying, you're almost challenging who they are as a person. And that's why people get so defensive. They get into these little echo chambers of collective groups, and they just sort of go down these mindsets. They don't want to look out elsewhere. So it's a very difficult one. I'm not sure how it will ever be addressed when some people are so focused on their way of looking at things.
And that's only exacerbated through Facebook, through social media, where these echo chambers are a real thing now. They're not just metaphorical. They're actually a legitimate thing that's happening. It's interesting what you're saying, because I completely agree. There are certain people that hold the philosophy so close that when you challenge the philosophy, you're challenging them as a person. And it's almost like the classic joke, like, how do you know someone's a vegan, or how do you know someone's a CrossFitter? It's like, well, they tell you within and it's the same thing. If someone's holding something so close, that if there's that bias there, it's very difficult to talk to them. on the flip side, we have people that integrate philosophy and clinical reasoning quite well. Is John Gibbons, the body master, I think his name is.
Oh, yeah.
And he's got some fantastic stuff here. His book on vital nerves, extremely more sophisticated and comprehensive than anything I got from postgraduate studies. Have you heard of MPI, Motion Palpation Institute?
I have heard of them, yeah.
Yeah, because I reckon you'd love their stuff. I mean, I've got the second edition of Principles of Dynamic Chiropractic Motion Palpation here by Len Fay and one other co-author.
That looks nice.
But yeah, it's a nice old book. But the reason why I bring it up is about specificity. They do a really good job explaining it, and they do a really good job bringing in some modern science, neurophysiology, and some of these terms and recent research to kind of, couple with some of these old school ideas. And one thing I like about them is that they teach a lot of more global palpation. So I remember when I first started doing palpation at school, they were saying to us, like, you have to feel each bone. And I remember thinking to myself, am I really bad? Like, will I get better?
I bet you were lying to yourself, right? You were telling the student, you're telling the teacher something, but in your heart, you were going, I can't feel fuck all. I can't feel anything.
Well, everyone does. I think any student would agree they've done that. So they can get their listing, so they can get their adjustment.
Yeah.
But I remember thinking to myself, like, I can't actually feel this.
Thinking about motion palpation, I'm not a fan of how that is taught in manipulation, because the idea that you can palpate these minute movements is unless you're Harry Potter, well done, because I can't palpate minute movements. I can't palpate 1 degree of rotation at the L spine. Do you know what? Interesting to where we've come from, but not relevant in clinical practice. So you can have one technique, but if it's described in a way that is outdated, it's almost looked at as pseudoscience and quackery. If you can explain it in a modern concept with current clinical thinking and rationale and clinical reasoning and neurophysiology, then it can be utilized as sort of a modern thought process around using a technique. So I'm a massive fan of looking at everything, learning as much as you can about something, being realistic about the ability that we have as practitioners. Yeah, we're not magic.
I would go and I'd do an MPI. I was also doing online MPI training, talking to Stephen, who was an MPI officer. For example, this is just a quick example. Rather than having someone prone and doing the old TVP motion on one spine, trying to see one TVP, and then going down the whole spine. They do a really cool one where you do this. Actually, you've taught this as a mobilization. I've seen you do it. You know, the one you get them up like this, and then you glide them.
Oh yeah.
They'll use that as a clinical tool. And I remember doing that and being like, oh, I can feel this, or this feels a little restricted. You know what? This does feel a little jacked up. Maybe that is going to impact how I'm going to treat the person.
I mean, I love mobilization, and I love the mix between testing and treatment. And I think being a little bit artistic, you can go through the joints. And now I'm not trying to feel its movement. I'm not trying to tell you its position. I'm just trying to tell you how the area is feeling. I'm looking for pain provocation. I'm looking for the patient to respond. Does it feel like it is a bit dysfunctional? Can we move into it? Does it ease off? Does it feel better? And then we'll just carry on. So the idea that I can tell you that something is misaligned, that I can palpate it, I'd have to have known where it started from in the first place to tell you it's out, right? And how do you do that in reality? Because the spine is not perfect. Everything is, if you've done cadaver stuff, you open someone up, you see how messy it is, right? The idea that you're palpating a beautiful transverse process and you can say, oh, it's side bent and rotated is utter nonsense, because you don't know whether that's its natural resting position. You just don't. So how can you tell it's dysfunctional? It's very, very challenging. It's a lovely idea. I like the idea. I wish that we had that ability of palpation, but our palpation gets worse as we get older. Our mechanoreceptors in our hands, they degrade as we get older. Our palpation gets worse. And ultimately, when you look at the research about clinicians, their palpation, even bony landmarks, you can't get agreement. You get groups of people trying to ascertain bony landmarks, and you'll get lots of different concepts. Trying to get someone to tell you what the position of a joint is in order to then try to decide whether you should mobilize or manipulate, I think it's a great way of thinking, but in the reality, I just think it's incredibly challenging. And I think you're shooting yourself in the foot, really.
And then you get into the treatment side of it, and we know that an adjustment can be anywhere from 4 to 9 segments, superior or inferior on the spine. We know that there's a frictionless interface between the fascia and the skin, and that this idea of doing a tissue pull was not what we once thought it was. So all of this stuff is really interesting, because I was learning one thing in school. I was learning that that a joint goes anterior, superior, right. It's an ARS, it's an ASR, it's an ESR, it's an ERS, right? It's an ASRP, anterior, superior, right, posterior, with the Atlas or with the C2 and C3. I was getting taught static positions, and then we were being taught to adjust in the corresponding vector to the static position. So everything's in this world where you're accepting that every spine's pretty much the same, that what you're feeling has no abnormalities, and that the spine literally shifts out of position, which is a lot to assume, especially when you look at some of these other research. So when I was looking into MPI, they would have research on this saying, hey, we know with the interface of the fascia, we know with the tissue pool, we know with specificity of motion palpation. And it's so interesting because I was having all these various things, and I'm like, man, I got to choose a side to go here, because I either go against Chiro, and I carry on this evidence-based thing. There's no way for me to integrate, because in New Zealand, I'll give you a little bit of a quick backstory. I think we've spoken about it before. You're pretty well aware. The New Zealand chiropractic school is philosophical based, probably not as you could find. Stephen will probably argue with that because he knows some around the world too. But I'm just trying to say it's old school, right? And what we're being taught is old school. There was no middle ground.
Mate, you've spent a lot of money on your degree. You've got a lot of time invested in it, and you're sat there listening to tutors talk utter bullshit at
That's
you.
what happened.
And you're having to smile and go, okay, yeah, where do I stand on this? And you just have to go onto Google and you can see half of what they're saying nonsense, but you can't say it because you'll get ostracized by the rest of the group. But I completely understand where you've come from and where it's very challenging. The idea, what I always found funny is that someone will stand there going, specificity. The vertebra is, I'm on this vertebra, I'm on that. I'm going to only do this, only do that. I'm that good. Then you watch them crack the person and it goes, and they crack everything. Oh, I'm only going to do L5 rotated left, side bent right, and I'm just going to do this manipulation. I'm only going to click that. And they body drop the lumbar spine like the guy owes them money, snaps the guy in half, and it cracks them from head to foot. And they go, woo, look at me. Boom. How specific am I? You're about as specific as a sledgehammer. There's no skill there. It's just brutality. But it just makes me laugh when I see these people talk about this movement and all this. Oh, yeah, all their fingers, or they run their hands all delicately over the patient. And then I'm like, dude, man, what are you doing?
I mean, this takes me to what we've talked about a little bit with social media. We have people, they are literally trading cracks and clicks and adjustment sounds some of them even have like girls with sports bras on the main display pic. They've got the microphone. I mean, they literally have their Bluetooth microphone clipped to the patient. And then they're just like, what is this?
I'm surprised they haven't inserted the microphone. You know what I'm saying?
What is
Trying
this?
Trying to get it closer.
What is this bullshit? Like, yeah, you're right. Try to get it in any cavity. You can a bass sound, and more of a quook. Like a coccyx adjustment. There, you get a real. That's what they taught us. When you get a proper SI or a proper coccyx adjustment, you know how you know you got it. Oh, well, it sounds really deep. Whatever. Shut up. That's bullshit, man. This does not need to be clicked onto the patient and then put on social media. It looks like and what it looks like to me is that you are selling any legitimacy of you as a clinician for some views and for some followers. I just think it looks cheap. And half the time they can't adjust anyway.
Social media, unfortunately, for all its positives, has a whole string of negatives. And when it comes to manipulation, I see a real issue with social media for a couple of reasons. Firstly, it creates a false reality of what actually happens in a clinical setting. You're talking about a 30-second clip of what could literally realistically be 6 weeks of treatment. And, you get unrealistic expectations for the patients that see this stuff. They expect to be fixed in one session, and treatment isn't like that. You get unrealistic expectations for new graduates that see this stuff and believe that that's how they should be in clinical practice. You get this unrealistic reality of what manipulation is or how it should be integrated. It becomes put on this pedestal as this monumental technique that is all encompassing. You get fake cracks, fake clicks. You get stuff that you would never do in clinical practice. They show techniques that are aggressive, are dangerous. And I look at social media and I bow my head sometimes in embarrassment, because I'm a massive fan of risk and reward. What is the risk to the patient for the reward? What's the outcome? Why am I doing this technique? What am I doing it for? Whereas some of these people, it's all for likes, it's all for credibility, it's all for virtue. It's a virtue game. They are getting their self-worth, their self-efficacy, their ego and their virtue through likes from random strangers. And in order to get more likes, they have to do more dangerous stuff. They have to have a bigger crack, a louder crack, to the detriment of the patient. And it's like, guys, manipulation is one part of the treatment. It's a small part. It's not the treatment. If all you do is crack the patient and nothing else, save the money and go get a month's gym membership, or save the money and go buy some ibuprofen. I would rather you did that than just rely on one fucking manipulation, because that's not the reality. And it really does. And again, you're talking these echo chambers. And another thing I see, sorry to digress, is that students coming on courses that basically believe that their ability as a therapist is dictated by how many followers they have on social media. One guy said to me, "Oh, yeah, I'm a really good therapist. Why? I've got 150,000 followers. I've got more than you." And I went, "Well, good for you." And it's like social media. Do you know what? It's sad because social media's produced these like mini celebrities of osteos and chiros. And when you watch these guys, it's the brutality. And it's the brutality of the technique. I mean, I love manipulation. And I love technique, but I love manipulation when it's done really gently and really fucking effortlessly. Any mug can crack a joint as hard as it can go. Anyone can get a sound out of a joint. That's if they're not putting the fake sounds in anyway. But good technique, good quality technique, it's just not sexy. It's not smash and crash. It's not these sort of like freaking, I call them like therapy Jesus moments where you smash someone and they're I liken it to like the old Midwestern snake oil, the snake oil sellers, the medicine guys would roll up into a town and go, "Look at my medicine, take a swig of this and you'll not be blind anymore." And that's unfortunately, humans are lazy and humans by nature want a quick fix. And that's what these people are selling. That's, and I mean, I can't stand looking at these guys measuring leg lengths and putting the before and after pictures of scoliosis and all this stuff. And I'm just going, my God, why are people buying this crap? It breaks my heart sometimes. And when I go on courses and I see people that have done other techniques and other courses, I'm not saying ours is by far the best out, but we do try to teach clinical thought process. My whole goal is, you're going to do a technique. Okay, why are you doing it? What are you intending to get out of it? And then how are you going to back it up with? What are you going to back it up with? So you've cracked the neck. Then what? What do you then do afterwards? Because you've got to do something, right? Are you going to educate them? Are you going to rehab them? Are you going to condition them, strength work? What are you going to do after the technique, right? Because that is a temporary thing. Yeah. And that is a small part of what is a big picture of treatment. Treatment is not a 30-second Instagram reel. That's not the reality of it. Trying to deal with unrealistic expectations, I find now patients coming to me going, "Well, I've seen this technique on social media, do this to me." And I'm like, "No, man, it's my room, my rules, get out." I do what I want to do. And I'm not going to be dictated to by anyone.
Yeah, fair enough. Along this line of discussion, would you be able to talk to us a little bit about your first patient visit, right? So the assessment that goes into the first patient visit. And the reason why I bring this up is because I tend to see a lot of people confused around to what extent should they be doing their checks, to what extent should they be doing their neurologicals or their assessments or their regionals, or should they be checking the cranial nerves, blood pressure, and there's as a chiro
I check their credit history, mate. Yeah. That's the thing I do. Can you pay us on that treatment plan? First, number one.
In the history, that's the very first thing. Yeah. Above the LOPS QRT, it's like credit, and you're gonna. No, it's I find a lot of people, in school we get taught so much. Like we got taught how to do every cranial nerve and every neurological test and every regional test, and we just get taught a lot, which is, I suppose, it's a good thing. But then you see, I would go to chiros who I know have graduated from the program I have, and they would do nothing. there was, you know, as a new patient, my new patient examination would be 0. It would just be like a history and then crack. So it's where is the middle ground for that? I've done the course, the OMT course on red flags, and you talk about, you know, bringing it down to blood pressure and the radial delay. And there's a few tips and tricks that I got from your website I really, really loved. So I thought it'd be cool to hear your thought on that, and then also hear your thought on how you personally do it in your clinic.
Right. So for me, I personally believe that the most important part of the whole treatment process is the case history. The testing, you can do all the testing in the world. You can know every special test you want, but for me, it all comes down to the case history. 80% of your diagnosis is made through a case history. You know, only something like 5 to 10% is made through special testing. 80% is a massive, massive aspect. You've already pretty much made up your mind what's wrong with the patient during your discussion with them before you've even touched them. So I'm a massive fan of a really good case history. We interrupt our patients way too much. We don't ask decent enough questions. We try to skip through a lot of stuff. So for me, I'm a massive fan of understanding what is the issue, what is the mechanism of action, what is the causational factor, what's led up to this point. Because, you know, they may come in with acute pain, but how have they got there? What have they been doing that precedes this? You know, and it could be days, weeks, months. I want to know as much as I can. In terms of the blood pressure stuff, I personally believe you should be taking blood pressure on all new patients, right? For me, it's the least invasive test you can do. In England, they give blood pressure machines to pensioners to do their own blood pressure, right? You don't need to do a special course to learn how to take blood pressure. I mean, we did Steph and Cuff, but my kids have that. I've got an electric one. I just stick it on and press start. You don't have to be freaking Dr. House to learn how to take blood pressure. But what an epidemic in society is high blood pressure. It's a silent killer. And in England, it's like 1 in 4 over the age of 30 are going to have undiagnosed high blood pressure. High blood pressure left for a long period of time, you've got significant cardiovascular issues. So don't worry about your back pain. Worry about the stroke that you're going to probably have. Yeah. Worry about pre-subclavial coarctations. Worry about the atherosclerosis. Worry about, you know, the fact that's going to end your life at 55. Don't worry about the fact it hurts when you put your shoes on. You know, so for me, a big thing is trying to screen my patients from almost like a holistic perspective. So you come in and see me, it doesn't matter what you're coming in with. I want to have a really good case history, a really good discussion. I want to look at your general health. I'll do some blood pressure testing. If the blood pressure is high, I'll do it a few times, give them the best reading, and then I'll refer them back to their GP to get it double checked. And I have caught so many people that have high blood pressure. They didn't know it, that they've then managed to do change their diet, go to the gym. 6 months later, no high blood pressure. They're in the best shape of their life. You know, that I think is a great way to treat your patients rather than just focus on that. In the moment, my back hurts. Let's do a technique. Let's try to change the symptoms. Let's try to change the function for a short period of time. I'm done. Pay me. You know, see you later. In terms of testing, I'm not a massive fan of doing a whole myriad of tests because they're very subjective. The validity is very, very poor on a lot of them. I think you get a better idea through case history. In terms of special testing, if I believe I've got to do a special test to rule out a red flag, I won't do it. I'll refer them. I'm not a fan of proving myself right just because I'm fucking clever. So, you know, if I believe that they've got a fucking DVT, I'm going to go, I'll see you later, mate. I'm not going to give it a pump and a squeeze to try and see if I'm right. Do you know what I mean? All right, let's check your aorta.
Yeah.
Hold on a sec.
Yeah.
Let's have a little fiddle around.
Oh shit.
Yeah, exactly. Hold on a minute. Oh, fuck, I'm right. We've got another one. Do you know what I'm saying? How do we get rid of a body in central London? It's really hard. So for me, why are you doing a test and how is it going to change your thought process? What are you doing it for? A lot of the time I'm testing and treating at the same time. But I do think case history is one of the most underrated things that you can do. And sometimes, like, I know from even from freaking I know, even from like almost like placebo, I can drop your pain levels down by just doing a really good case history. Just by listening to you, you're going to feel better.
Yeah.
And if you like me, you're going to feel better even more. And if I sound like I know what I'm doing, you're going to feel better even more. And if I'm confident, you're going to feel better even more before I even have to touch you. So I'm a massive fan of actually really listening to the patient, because we don't do enough of it. We really don't. A lot of our profession, unfortunately, has ego. In fact, ego is, I mean, you're a big guy, you train. Probably the first thing they said to you was leave the ego at the door, right? And that is exactly what it should be in clinical practice. Leave the ego at the door. The treatment is about the patient, not about the therapist. It's not about how hard I can crack a joint. It's not about how amazing I can do a technique. It's about trying to help someone who is in pain at that moment, reduce their pain, and then improve their quality of life.
Yep.
Through whatever mechanism that we're going to do. I started osteopathy because I had so many questions. I mean, probably like yourself, I'd done lots of other courses, lots of other qualifications. And then I got to the point where I need to know more. Got to osteopathy, thought that was going to teach me everything. Got to the end of osteopathy with more questions than I had answers. And I graduated after 5 years going, I don't know anything. And then I felt like I was on a journey on my own, which is when we started going into research and writing, because what I realized was the stuff that I'd been taught 15, 20 years ago actually was complete nonsense, and it wasn't relevant, and things had massively changed. And it does take a big person to turn around and go, actually, I was wrong. When I did that back in the day, I was repositioning your pelvis, right? I can correct a pelvis with my eyes closed. Oh yeah. But now 15 years later, we know that we're not realigning stuff, but we are still having a positive effect. But why? The why has changed. And it takes a big person to go, actually, we need to move along with current thought process and actually have a clear understanding of what it is that we're doing and why we're doing it. But it does take a big person to do that, really. And that's why you guys doing your research and publishing your stuff, it's a credit to your colleagues and a credit to your fellow chiros, because it forces them to actually push forwards. We've had a lot of issues in our industry, especially in the UK. And there's some research that's just been published, questioning a lot of osteopathic philosophy. And there's some really interesting guys out there pushing research and podcasts, basically talking about the issues around our profession, and bringing it to light, because some people are embarrassed to do it. They're worried to do it. They've spent a lot of time and a lot of money getting that title, and they don't want to question it because they don't want to upset the apple cart. They don't want to go against their peers. And it's sometimes easier to put your head below the parapet.
Yeah, we've been really what's the word, I suppose, not lucky, but just positioned in the right time for the right thing to happen, in terms of some of the colleagues and the friendships I've been able to make that have led to various research, and even the CFMC, the College of Functional Movement Clinicians, directed by
I've seen
Dr. David Johnson. So it's just come out of it's bubbled up out of this frustration, and not talking to you, an osteopath, and you talking about all these problems, talking to Stephen and all these problems. Often Stephen and me will say, we will talk to people from all around the globe in these podcasts, and we all come up with the similar issues in the medical system. And because of those issues bubbling up to the surface, especially with lower back pain, Dr. David Johnson, a neurosurgeon, which is fairly I've always thought of a neurosurgeon and those types of people as top of the hierarchy, if there was one, if you thought there was one. And it's a bloody neurosurgeon has had to come off his little mantle as a neurosurgeon, learn movement therapy, learn how to move with a barbell, kettlebell, dumbbells, learn hip-centric rotation, neutral spine, posterior chain powered movement, learn these principles and these protocols, because he had back pain. And then he realized, my gosh, everyone that's coming to me are all coming to me saying, I've seen every osteo, I've seen every chiro, I've seen every physio, I've seen every AT, I've seen everything, no one can help me. I'm at the end of my rope. I literally don't know what else to do. And he looks at it and he goes, we can help you. He doesn't cut into them and do an anterior cage or posterior pedicle screw or whatever. He puts them into Neuro-hab, 8 weeks movement therapy, where they learn how to move, they go back to, they regress to progress. And majority of his patients now that come to see him seeking an intervention of the knife, lead out of their office feeling empowered to do something that they can take hold of, which is movement therapy. And then 8 weeks later, they haven't just, they don't just feel better. Based on our research that we've actually conducted, it's a 50% decrease in ODI score and pain scores. But not only are they feeling half better, they're also turning up to train right next to him. David says to me that he trains with his patients every day. So these
I love that.
I love that. when I connected with David, I come from a very similar thought process. I said, man, this is something we get behind. And obviously Dr. Andrew Locke in a similar way, talking about what you're saying with different people trying to push forward this new kind of ideology around what we're doing, which is it's also based in clinical outcomes, right? The importance of assessment, clinical outcomes, but it's based in research as well. We also have some of the largest social media presence, or you say influencers, right? We with Scott University, with Aaron being on board, like he's got one of, if not the largest social media platform, Instagram platform for manual medicine / rehab stuff with over 2 million. And we're able to push a lot of good stuff through that channel, which I sincerely hope helps people. But it's all very similar stuff to what you're saying. In the theme of collaboration, I had the honor and the privilege of collaborating with you recently. It's very exciting because slowly I get to research and write and talk about and publish things that I'm just interested in. And we're doing an X-ray one at the moment, which is going to be head turning in the industry, I'm sure. The one that we got to do was obviously on HVLA versus LVLA, or spinal manipulation versus mobilization. Do you want to give us a quick overview of the collab we did? And then also our article has been accepted to be published in the British Journal of Research as well. So that's cool. That's all kind of just happening behind the scenes. But do you want to give us your thoughts on that?
Yeah, so I'm a massive fan. Mobilization and manipulation, basically two modalities that as osteopaths and chiros, we are sort of inherently trained in. Mobilization is seen as a low velocity, low amplitude joint movement where we're just mobilizing the joint to create this neurophysiological change. And then manipulation is where we put a thrust into a section, just looking at gapping a joint to create a symptomatic and functional modification for a short window of time. I love mobilization. I really do. In fact, it's one of the reasons why I'm very good at manipulation is because I spent many years not doing it. I spent many years mobilizing and actually getting an understanding of how a joint moves for that person, because manipulation is not painting by numbers. It's not 1, 2, 3, bang. You have to have an element of finesse when you're moving someone into a position, because everyone's a little bit different. Big, fat, small, thin, male, female, stiff, flexible. Everyone has this slight intricacies that you have to account for. And if you don't account for it, you just use brute force and ignorance in the technique. So for me, I love mobilization. I think it's very underrated because it's not very, very sexy. I mean, I wrote a whole book on mobilization. It was my second one I ever wrote because I really love the technique. Patients love it. It's a great way of just getting the person moving. You get some great neurophysiological mechanisms going on. You can reduce pain, improve movement, reduce tone. You get a lot of these positive benefits out of it. And you can get the patient to do it themselves. You can take them through their own movement and actually give them coping strategies to mobilize their own back and neck and things. Whereas bit difficult telling the patient how to crack their own neck. You know what I mean? Run at a wall like this and see what happens. Do you know what I mean? Yeah. I'm a big fan of it. I do it all the time. It's one of the techniques that I teach. I don't teach mobilization as much, unfortunately. Like I said, more people are now have a bit of a thing about manipulation. But I do believe to be a really good manipulative therapist, you should have a really good understanding of mobilization and how to use that.
Yeah, I thought it was fantastic when I started speaking to you about the differences between the two, because I was on a very similar wavelength in terms of what I believed. And I know when I speak to chiros, I usually get talk to the hand when it comes to me asking, hey, what do you think about mobilization? And we actually learned a whole load of a zero mobilization in our course. And it was all, when I asked my teacher, what about mobilization? He said that it's just motion palpation, and that if you do too much motion palpation, yeah, the joint may feel a bit better, but it's going to go back to how it is within 10 minutes, as you need to actually create the neurophysical change through the cavitation effect or the full adjusting effect. So that's what my professor said. And I said, well, if you don't cavitate, is it an adjustment? And he goes, well, yeah, we know it's not all about the cavitation. And I said, well, you just contradicted yourself. But, one of the first...
Loser.
Yeah, exactly right. One of the first, if not the only, not the only, but one of the very few chiros that I've asked about mobilization, and the answer was, yeah, it's great. Yeah, I use it. Yeah, it's pretty much just as good, if not as good. And it's all about the assessment and the clinical reasoning behind what you're doing, is Stephen. Because, every other chiro I spoke to pretty much would give me talk to the hand. Stephen, do you want to give us your quick thoughts on that?
I love mobilization. So I'm also a massage therapist as well. Almost anyone who's licensed to touch the body can do a mobilization. So when I'm teaching my students about mobilizations, I encourage them to learn how to do them. I'm like, this is not an adjustment. This is not a manipulation. It's a mobilization. You're getting familiar with how the joints are actually moving. You can find restrictions in there. You can free them up. You can modulate the pain really well on top of all the muscle stuff you're doing. I love mobilizations. I do mobilizations on a lot of patients. I know Brogan's seen some videos where I will do some mobilizations at times, and then I'll do a manipulation afterwards. If I feel like I wasn't happy with it and the patient wasn't happy with it, then we'll go in and sometimes manipulate. Sometimes I only mobilize. I had a patient recently, they're a medical doctor. They don't like their neck being adjusted. And so that's fine. There's other ways to do it. They're like, oh my God, are you serious? And I was like, yeah. So they came in, had some facet irritation in their neck. They probably did need the manipulation, but we're going to go through some mobilization stuff first. And she was like, I really think you should do that thing that I don't like. We did the mobilization. She was moving better, but she wanted to move even better. So I was like, sure, I'll send it. But I love mobilizations. I use them all the time. I do mostly mobilizations on the wrist and the forearms. I'll do some mobilization with the lower extremity as well to lead into a manipulation, because those things are stuck. We're on our feet. There's 30 plus joints in each foot. They're under a lot of stress. So mobilizing first, you're going to free up some of those things that you get these crazy cavitations, even mobilizing those feet, because there's so much pressure on them, and people respond really well to the mobilization. And it's gentle, but it's not sexy. It's not sexy at all.
Depends what you're wearing, mate. Depends what you're wearing. You know what I'm saying?
Yeah. Well, if you're wearing these glasses, everything's a little sexy.
Yeah.
No, but look, the only difference between mobilization and manipulation is speed. Yeah, that's it. The speed at which you're doing a technique. And testing and treatment, again, is speed of what you're doing. You test something, you treat something. I will always tend to mobilize prior to manipulation, and actually I quite like mobilizing after I've manipulated. So I'll manipulate, and then I'll spend a few minutes just mobilizing the structures once we've had that slight change. I look at it as a bit of imbibition of the structures, get a little bit WD-40, getting the patient moving a little bit better, feeling a bit better. And it's when you do it well, it's gentle. It's a real nice little dance. It's easy. The reason why it's not done is because people do it badly. Yep. They do it. It's fatiguing for them. It's hard. And I'm not a fan of the sort of the Mulligan, Maitland type stuff, which is all very much push in and fingers and thumbs. Whereas I'm a massive fan of this sort of gentle, rhythmical movement, gross movement, global movement. Take the patient through the positions they want to move into. You can really do some great stuff. Peripheral stuff, mate. You've got 33 joints in the foot. You've got a shitload going on there. And I will always mobilize into that bad boy before I manipulate, because I look at it as almost like romancing the joint. Dinner, drinks, candlelight, little walk by the beach. You romance the joint with a bit of movement, get the patient used to it, so that when you do manipulate, it's a nice, finesse, gentle little flick. If you don't do that little preemptive sort of just touching base, then you're going to have to smash the joint really fucking hard. So I'm a big fan of just working through, getting some movement, getting some palpation, just getting some joint play, and then you can see what's going to be right for the patient, because literally everyone is a little bit different. And that's where your skill comes in. You can crack someone's neck, you're going to add a little bit more flexion, a little bit more side bending, maybe a little bit more rotation, a little bit of compression. You're going to do a little bit of this, a little bit of that. It's not just 1, 2, 3 whack. That's where the mobilization comes in. That's what gives you that little bit of intricate joint play at the end. That's what takes you from being, a manipulative therapist to being a fucking good one. Having those sort of soft hand skills, having that sort of gentle ability to move those structures. And I've got to be honest, patients love it. They really do like that type of movement, because it is really quite safe. It's quite effective.
Yep.
You're going to get some nice results out of it. And if the person doesn't want to be cracked and they don't want to have their neck manipulated, then you can spend 5-10 minutes just mobilizing through the structures. A bit of translation is lovely, really nice to do. But it's not, unfortunately, it's not a sexy technique,
Yeah. And as popular as spinal manipulation has become, there are still people that are scared by it, and there are still people that won't want it. And it's funny because my wife and even my mum, they don't like manipulation much at all. And I've seen chiros, osteos, I've had multiple people adjust them. They're just not big fans of it. And when I started doing more mobilizations with them, they really responded better because they were able to relax, and you had the extra placebo boost in there. We were driving past a clinic yesterday just in town, and on the side it literally said like wellness center, and then it said something along the lines of like soft treatments, and it went as far as to say, like, on their signage, no manipulation, because they wanted people to know that we're not cracking joints, because there is a percentage of the population that feels it's a little bit daunting to them to come in and get crunched, especially when people are so heavy-handed, and not everyone adjusts as beautifully as you two.
I would say I had a patient come to me, and I hear all the time, have you had a treatment before? Yes, I saw an osteopath, or as I like to say, a psychopath, because they tried to rip my head off. The funny thing is, it's like there's a million ways to treat someone's pain. You can rub it, wiggle it, crack it, stick a needle in it. You can exercise it. You can pray to it. You can whisper to it. You can use freaking religious doctrine. There's a million ways. And if the patient gets benefit from standing on their head, stand on your head. One technique does not rule them all. It's not Lord of the Rings. You know what I'm saying? That's why having other modalities is a really important process. I mean, I was trained originally as sports massage, right? So I'm always going to do an element of soft tissue technique as part of my treatment. I'm always going to put hands on, because it's such a great way of connecting with the patient, creating trust. It's a great way to get some sense of the tissues, a great way to get a little sense of actually how the patient's responding. There's always a different way of doing something, and having various different skills, I think, is only for the benefit of you and for the patient. If all you can do is crack something and someone comes in and says, I don't want it, well, you're a bit stuffed then, aren't you?
Yeah, it's interesting because in New Zealand, unless you're specifically licensed to do so, which is chiro, osteo, and physio, you cannot touch the neck. That is by the Ministry of Health. That's a no-go unless you have a specific license to do so. The interesting thing about that is that yesterday I saw, and I think it was in America, there was a young lady that had 4 strokes on the chiropractic team.
She did. That was last year, wasn't it? I think I saw the newspaper article. Some young university student had a chiropractic adjustment, and she had a proper issue on it.
So it happened last year, but they did a follow-up seeing how she is now, and obviously she's alive, but she's severely disabled. It's really sad to see, and it's something to, I suppose, touch on, because as a practitioner or a clinician or a doctor, what we are seeing and how we are approaching our assessment is of the utmost importance, because if you miss something and then you go kung ho and you rotate the shit out of someone's neck and something happens like that, it's obviously it's worst case, right? But then obviously when you look at the research, the research says it's one in a million. The research says that it's likely the person is coming with the issues, right? People come see chiros and osteos because they already have the headaches or the neck aches. So often people say that there's an association, there's no causation, and that's what we were at with the research. But that's enough to freak me out, to the point where I'm like, man, if you've got other tools in the toolbox, such as mobilization, why not just check the neck. If there's a restriction in the neck, write it down, mobilize soft tissue, do your thing. Ask them to come back. If it's still there in a week later, then it's called patterning. People do this in chiro, maybe osteos do it as well, but just pattern it on the first visit. You know what I'm saying? Like, don't just send it. If you're feeling if you're feeling like there's something there, or if you're worried about anything, just like you said, refer, rather than trying to prod around and prove that there's something happening with their arteries or vertebral arteries. But that's a pretty horrible thing to see, and surely it's avoidable, wouldn't you say?
I'd be interested to see what actually was the technique that was used on her. That I don't know whether you know anything. I'd be interested to see what actually the chiropractor had done in terms of the manipulation, whether it was like an aggressive Y strap type movement or whether it was a rotatory thrust. That I'd be interested in seeing. For me, no one's ever going to criticize you for being cautious. They're only ever going to criticize you if you're being cavalier. No one's ever going to say to you, "For me, mate, you're way too safe." They're going to criticize you because you've basically just cracked the neck because someone's come in with an ankle strain. And so I appreciate it's true, right? Is true. Now there's risk in everything, right? Crossing the road, there's risk. Going to the gym, there's risk. But we have to factor in that. For me, when I'm using a technique, I'm a big fan of risk versus reward. Why am I doing it? What's the purpose of me doing it? So if you come in and you see me and you have back pain, I am probably not going to crack your neck, right? Because I can't really correlate the two. If you've got an ankle problem, I'm not going to crack your OA because of this minutiae of the butterfly effect of some sort of weird spinal movement. I'm not going to do it. Yeah. If you have neck pain, then I'm probably going to go, maybe we'll look at the neck and a manipulation might be appropriate. But for me, it's going to be, is the technique appropriate for the person in front of me? Have I done a thorough case history to make sure that the technique I'm using is safe? If at all I'm concerned and I don't think and if I'm unsure as to what I'm doing, then I won't use an aggressive technique and I will go, well, let's treat you conservatively, refer you for what we need to refer you for, come back, and then we can always add manipulation, but you just can't take it away. You can't take away a Y strap once you've done it, right? Yeah. You know, it's like making a cake. You can always add sugar, but you can't take it out. And that's the same with treatment. You layer your treatment, you layer it, and you add and add and add. If something comes in and it doesn't look right, it doesn't sound right, something on the back of your head is there, you've asked the questions and you're just not sure, be conservative. Be conservative and be safe, because you're the one that's got to pay your bills and you're the one that's got to pay the mortgage. If you do something and something comes wrong, it's your insurance, your license, and your title that's at stake. So for me, I'm a big fan of always making sure that we've done a full assessment, that I'm only using the appropriate techniques for the person in front of me, and I can clearly justify on a piece of paper why I've done it, what the outcome's for, and what I'm intending to get out of it. What I see too much on, especially on social media, is people using technique with no clinical thought process. They come in, they'll do a flying seven, they'll just do a pattern manipulation, neck to foot for everything. Now, 90% of the time you'll be fine, but some point in your career, something will up and you are going to be in trouble. There are a lot of people out there with huge therapy egos doing stuff to people with no clinical thought process, with no real idea as to what's going on. They're just cracking the fuck out of them and just, hoping for the best. I'm wondering how many issues are being caused globally that we aren't aware of. I really am, especially in some of these other countries where I go to, and I see some of these techniques being done to people. Like in India, they'll do like an OPD thing where you'll get 40, 50 people just come into a room and the therapist will just crack out of everyone. No case history, no nothing. Just come in, smash them to pieces and send them out. Yeah. Give me some money and see you later. And it's like, how many of those go on to have problems?
In the US with the chiropractic schools, the students will get together with these licensed chiropractors, and the chiropractors will take them down to South America where they don't speak English, and they'll just line the whole city up and rack and crack them. There's no one to translate. There's no informed consent. There's no history, no nothing. It's just racking and cracking a bunch of strangers, and then you go home in a week. So what happens? Like, they don't continue with care. You don't know if you make things worse.
This is my big thing is consent, right? Because the problem when I say to students, right, what you do in a treatment room would be classed as an assault on the street, right? What you do to a patient in that treatment room is grievous bodily harm to someone on the fucking pavement. And you could be arrested for that, right? Yeah. The patient has to consent to allow you to do the techniques that you are going to do. They have to understand what you're doing, why you're doing it, what you're trying to get out of it, so they can say stop. They can say stop at any time. Just going in and smashing someone from head to foot for every conceivable systemic issue, from height issue, from health issue, it is not treatment. It's just literally a money-making scam. And I was teaching some, no disrespect to your chiros, I was teaching some chiros over in Asia, and one chiropractor was telling me that they have a whole clinic set up to manipulate children to increase their height. Right? They had trampolines. The kids would come in, they'd get smashed up, jump on the trampoline for 5 minutes, and that apparently helped them get taller. And I was like, at what point do you see this? Oh no, when they're about 18 or 19. And I'm like, that's like freaking 10 years of treatment right there. That's a proper fucking money spinner. I'm like, I'd like to see the research on that. But it does worry me, actually. It really does. I see some of these osteos doing these techniques and ratcheting people across a table.
The interesting thing with chiropractors is obviously they are trained quite heavily in imaging. They often use that to their advantage in various ways. I won't get into the whole imaging thing, but because I'll go on and on.
Position 1, position 2, yeah?
Yes, there you go, right? There's extreme
I've got scoliosis.
Yeah.
Oh, no, I haven't.
Stand on one leg. But the thing is like they will use
2 mil difference.
Yeah, they will use that as a rationale for clinical intervention, and also as a rationale for how long or when they want to see you. But what happened was, unfortunately, what happened with my dad was he was a tradesman and he had back pain. So he went to see his chiro, and I suppose now being, educated and understanding these things, I would think based on his age, previous lifelong smoker, older than 50, extreme low back pain that is not going away. You think there would be a red flag, but the chiro did no imaging, and the chiro adjusted him for about 6 months with no imaging and no referral. He collapsed after 6 months of that treatment at work, went to the hospital, stage 4 cancer. You've got 9 months to live, died 6 months later. And this is when I was 17. So I'm sitting here as a 17-year-old going, what is this quack? Like, why would you go see a chiropractor? I say to him, what did he do to you? And he said, well, it said doctor and it said back pain, and 2 and 2 together. And he went in there thinking that he was genuinely seeing a medical doctor or MD or someone that's trained at that level. So that's why a lot of average people in the population, in the public, they struggle to differentiate because chiros have the doctor title.
That's not the first time I've heard of someone being overly treated, misdiagnosed, or have something missed. That's a long period of time to be treating someone and not actually thinking maybe we should refer them for testing. If something isn't changing as you would expect, have the confidence to go, we need to refer you out for an image. Like I said, you'll never be criticized for being cautious. Yep. You'll only ever be criticized for being cavalier. And just because I've had training in assessment and diagnosis and testing, I'm not very good at it because I'm not a doctor. I don't do it day in, day out. I'm not going to look into your eyes and check for copper wiring, right? I'm not going to do it. I'm going to send you to the optician who has got a massive machine that's going to be able to look into your eyes. I think sometimes especially in the professions across the world, I think some people are doing things and treating patients that are way outside of their scope of practice, and again, I do think there's a big ego that needs to be pushed down a little bit and realize that we are there just to help MSK pain. We're there. That's what we do, right? Outside of that, that's not my remit. That really isn't my remit. I'm using these techniques as part of my treatment process. I'm not going to use this technique to freaking cure your liver issue or cure, all this sort of stuff.
Yep. It's funny because on the flip side of this, I agree fully, but on the flip side of this argument, on the complete other side of it, just to be devil's advocate, and Stephen knows where I'm going with this, but like Stephen, for example, has had like quite a few now that I feel like they're stacking up, Steve. But Stephen will like message me and tell me questions about people he's seen, and when he looks through the people like prior treatment, has been like pretty poor, but then like stuff's been missed, and then Stephen's like having to contact doctors and be like, I think this person's got like hypothyroidism and like legitimate medical things. That,
okay,
like
a
chiro should not be, it should not be on Stephen's shoulders to pick that up. But that's happened a few times, right, Steve?
Yeah, and that comes back to Giles's mention of a thorough history. You do a thorough history, and you're going to pick up on those things, and you'll make that clinical correlation, and you're like, get the heck out of here, because I don't deal with that. And then you send them to the person, they're like, oh, no, it's not that. There's no way it's that. You're a chiropractor. You don't know that. I'm like, okay, now you need to go find someone else, because now they don't even trust a healthcare professional to send the patient to see them. So go find another one.
Yeah. And you've done that, right? You've had them come back and they're like, it's not that. So you sent them somewhere else and it was that. It's just like, what? Yeah. Like, you know?
Do you know what? This is down to good case history. Because look, unfortunately in the UK, a doctor will have, if I go to my GP, I think you've got around about 7.5 minutes, 8 minutes. That's pretty much as much time as you've got, really, especially now post-COVID.
Yep.
So those poor guys have got tons of patients, 40, 50 patients a day. They're trying to get through as much as they can. And to actually sit down and talk to someone for 15, 20 minutes and do a thorough case history and try and pick up some of these nuances can be very challenging. So they do have a tough old time of it. And it's down to us as primary healthcare professionals to be educated and to do, to be educated and to do research around screening, common questions, asking someone about their general health, asking someone about, blood pressure, doing these types of tests, because we are going to pick stuff up that they may not. Now, ultimately, as healthcare providers, we're not there just to treat the MSK pain. We want to look after their whole holistic health, right? Their, mind, body, spirit, their health. And so if we can pick stuff up, again, it's for the benefit of the patient, but it's a difficult one. But if you're not doing a good case history, you're shooting yourself in the foot straight away.
Yeah, it's funny to just touching on what you talked about in terms of them having not a lot of time. I often tell the story about how someone that was high up in one of the colleges that I'm aware of was telling us a story about how he got his patient times down to 2 minutes. And he was like gloating about it, but he said,
it's a bit like my love making.
exactly right, especially after you have kids. But it's like the funny thing about it is that he was kind of gloating about it, and then he said to us that he did a survey. He would regularly do surveys asking the patients not just about their perception of his quality of his service, but how long they thought they were spending with him, and they would often put down 20 minutes, 10, 20 minutes.
Wow.
And he's doing 2, so that he had it down to the point where he would have a great receptionist, a great a vibe of people up the front, that he pays well to make these people feel like they're in a community, they're a part of something, and they would talk to them and they'd get them seated and they'd have whatever, and then you'd go in and you'd see him. But he set it up in a way where he would rack and crack, and he would do it on a subscription basis. So you pay for a subscription, you come in as much as you want. And he would often tell us that he made millions and millions and millions of dollars in this way. And he would often encourage us to do it that way. So that was pretty early on. And at Chiro School, I was pretty shocked with that. Following on from that in a very different fashion, we had Matthew, a physician's assistant and also McGill certified practitioner, on the podcast last month. And often McGill will talk about, his first assessment being 3 hours, 4 hours long. He came from a PhD, as we know, he's a researcher, a PhD, and he often talks about not having clinical training being his strength, in the sense that he wasn't taught how all these rules on how you have to see someone for only a few minutes. And so when he started the program, he said to them, like, I'm going to need 2 hours, when they wanted him to start his outpatient clinic at the University of Waterloo. And he said, I'm going to need 2 hours. They laughed at him. All the clinical doctors, there's just no way. Anyway, he came back to them, 8 weeks later of trying it out, and said, okay, scratch that, I need 3 to 4 hours. So, and this is, and we talked to Matthew about it, and Matthew is like I said, he's a physician's assistant, and he works at a chronic pain clinic where he prescribes oxy and all different types of morphines and pain medication for people that just can't get off this pain cycle. And he will talk to them about other options, movement therapy, based in McGill stuff, and he'll handpick people that are open to it and treat them at his personal clinic and see them, help them get off this kind of drug cycle. And I just found that to be such an impacting story, such a amazing thing to hear. He goes from seeing what's worse, the worst of the medical industry by day, and then trying to do what he can to help these people by night. Very contrasting, isn't it?
It's like Batman.
Yeah, I say Batman, right? But I know you said you got the kids to bed. I don't want to take you any longer than we have to. It's Sunday night in London. Am I correct? Good old London.
Yeah.
Bloody
exactly.
London.
Exactly.
Go down for a bloody pint, maybe some mushy peas. I'm not sure. You come there. No, what's that? Is that in Manchester?
No, that was a terrible accent. But you're a big man, so I'll let you get away with it. It's
yeah,
fine.
well, we're not across the room from each other, so you can pretty much get away with anything. Can you give me your best Kiwi accent, please?
No, I can't. I would embarrass myself if I tried. I don't know how to do a Kiwi accent. Don't you just go up in an octave at the end? It was that Australian.
I think that's Australian. I mean,
yeah, I don't know.
Sometimes I try to do like a California voice for Steven, but I can't really do that very well either. Like shaka bra, let's go surfing. I mean, not that you're from California, Steven, but anyway, we should move on. A couple of things I want to square off before we end the podcast and we get your beauty sleep, because international bloody bestseller.
I don't have to worry now. I just filter it up. I just filter it up now.
Yeah, easy. That's the beauty of it. Eh?
Yeah. Just big eyelashes and lipstick. It's fine.
Here's a big one that I really want to hear your thoughts on. How do you integrate exercise into your practice as an osteopath or as a manual therapist?
Okay. Exercise to me is probably one of the most important parts of the whole treatment process. In fact, I always say what the patient does off the table is way more important than what we do on it. And if the patient isn't engaging in some form of exercise rehabilitation, I don't think that you're actually going to get the results or the long-lasting results that you're looking for. So for me, I use manual therapy as an adjunct to get my patients into a rehab phase as fast as possible. I use manipulation, mobilization, and a lot of it is down to creating symptomatic and functional changes for a temporary period of time. And then I'm desperate to get them into a strengthening phase. I want tissue resilience. I want loading. I want movement. I want them to be doing everything that I can get them to do as best as I can. Now, not everyone's going to do that. There's a big non-compliance, and that's where education comes in. That's where setting realistic goals comes in. I'm a big fan of the 1%. Giving my patients 1% improvement on a regular basis leads to big changes. If that means them starting off doing a gentle walk once a day, that's it. That's brilliant. If they're active and they can understand exercise, giving them strengthening concepts they can do, or I'm a big fan of getting them in with an S&C coach or a personal trainer or someone who understands good movement and actually doing some coaching, because I'm a massive fan of actually, if you invest in it, you're going to tend to go and do it. So actually come and see me for a couple of times. Let's bring the pain down. Let's get you moving better. Then go and see a colleague for 2 or 3 times, get them understanding what I need them to do. And then you can come back to me for a bit if you need to. But ultimately, the goal is to create some tissue resilience, create some strength, create some movement, get the patient understanding what it is that we need to do to make long-term lasting changes. That's where I believe it comes in. And I'm a massive fan of educating the patient to say that the exercise is the most important thing that we need them to be doing. Education and exercise off the table. I see them for half an hour once a week, man. If they're not doing something outside of that, then we're going to be, it's the classic. If you always do what you always did, you'll always get what you always got. We need to break the cycle. We need to do something. And tailoring the exercise to the person. So it's realistic, it's achievable, it's measurable, smart concepts. Make sure that they can do it. I'm not asking them to juggle on a bozo ball, but, they get off a bus stop earlier and they can walk an extra bit. You can get some great results. Slow, methodical, achievable, realistic goals, I think is very important.
So how do you deal with a patient that is not adhering to the protocols or the things that you've set out for them?
I'll take their money and keep seeing them. What can I say? Look, I'll be honest. If a patient comes in and I say to them, look, I need you to go and do this exercise, and they're going, I don't want to do it, well, I'm going to go, fine. Look, I'm going to tell you, I'm going to educate you. I'll keep you in the treatment process. I'll manage you. Do you need this manipulation? No. So I'm not going to crack you. I'm just going to do some soft tissue work, do some mobilization. And every time I see you, I'll educate you some more about the importance of exercise. But if you're not going to do it, I would rather see you than send you to someone else who may not treat you as ethically as I will.
Yep.
As much as I want someone to train, I can't expect people to train as much as I do, because I love the gym. I love to train. I love exercise. I love rehab. I love doing all of it. But some people don't want to do it. Our job is to try to educate them and try to encourage them and try to give them the motivation that they need potentially. Our job is to be the coach, to guide them, to coach them through. Our job's not to be Rocky. Our job is to be that weird little guy in the corner with the hat teaching them. That's our job. The glory's not on us. Our job is to give the patient the glory that they're going to achieve the result that they want. And that might take a few weeks, months, it can take a long time. But that's my thought process.
Yeah. Yeah. And for those that are listening, and even for those that are watching on YouTube, you definitely work out because you're very jacked. I've seen some.
Stop.
I mean, I just got to throw it out there. I think. We'll put up an image for those watching on social media or YouTube, maybe. But you're definitely in shape, and I think that's a really important thing when it comes to being a practitioner or a clinician, is that you yourself are adhering to these protocols that you are also prescribing.
Listen, I'm not going to give someone an exercise if I don't know how to do the fucking exercise. Do you know what I mean?
One real specific question I have for you is, in terms of with you and the patients you've seen, have you ever, I'm sure you've had patients that smoke, and
yes.
I'm interested to know how do you approach smoking with a patient? Because in your mind, you're thinking, I can help crack your back, I can do soft tissue, I can modulate your pain. But in reality, as a healthcare professional, the best thing I could probably do for you is talk to you about the smoking. But then I know people are extremely touchy. It's probably a similar thing with obesity, but that's probably even more touchy. But do you even touch on it? Do you just leave it? It's not your problem, GP's issue? Because if you could discuss that issue, I mean, imagine getting someone to stop smoking. I mean, that's probably the greatest exponential health outcome you could have, even though it's not your job. Yeah. How would you, I've asked this question before. I find it really fascinating.
So I would use acupuncture needles to sew their mouth shut, and that would sort of resolve the smoking issue. I've got to be honest, I personally am a very honest person, and I am very honest with my patients. I think I have a duty of care to my patients, not just to treat them from an MSK perspective, but also to discuss aspects of, things that can help them from lifestyle changes. And so if someone comes in and I say to them, do you smoke? And they say, yes, I'd always say, look, you know the issues with smoking. Have you ever thought about giving up? And if you want some advice, I can point you in this direction that potentially you should go and maybe think about it. But I think we're healthcare professionals and we're healthcare providers, right? We're not just there to treat your back pain. We're there to look at the whole person. And also things like anxiety and stress and sleep management and nutrition. I'm a big fan of, look, I can crack your back all day long, but if you're not getting a good night's sleep, I'm a massive fan of saying to my patients, look, turn your phone off an hour before bed. Let's work on anxiety. Let's work on stress management. Let's work on some breathing techniques. Let's look at how can we reduce your stress and anxiety. And actually that may in turn help your back pain.
Yeah.
I'm not a psychologist, and I have to be very clear on what my scope of practice is and what my remit is, and refer to people that have better knowledge than I do. But I am a big believer that we can do things to assist people and give them advice that can have some greater impact than just clicking their back.
Yeah.
If you can feel better, move better, if you can sleep better, if you can life at the moment is a very stressful thing. Sympathetic nervous systems through the fucking roof. Our phones constantly aggravating our systems all day long. We have a constant anxiety, a constant stress, right? At no time in our life we ever had so much information chucked at us at one stage from a little tablet. So if we can try to reduce someone's stress, help them with, nutritional education or slight lifestyle changes, I think that is for me a really important thing. So I'm very honest with my patients, and I'm quite blunt as well. I'm quite an open and a blunt person, and I do believe that there's a balance. I'm not being offensive or rude, but I am saying, look, as a healthcare provider, smoking is bad for you. The evidence is there, and I think it should be something you should consider, if not now, but maybe in the future.
I interrupt this podcast to thank Raisies for sponsoring the Strength Chiro podcast. Raisies is a family-owned New Zealand business that only produces high-quality, all-natural and clean products. If you're anything like me and you need a protein that tastes good, mixes well and contains no additives or nasty preservatives, this is for you. This protein is New Zealand-made, ultra-filtered, gluten and GMO-free with no artificial flavors or colorings. If you are an athlete or you love to train hard, it's essential that you get an adequate amount of protein. We would like to thank Raisies once again for sponsoring the podcast. You can get 10% off at raisies.co.nz. And a real quick specific question. I recently had someone reach out to me asking me, they said, look, there's research saying spinal manipulation has a sympathetic effect. There's research saying it has a parasympathetic effect. Obviously, you've done extensive research on this as well. What would your answer be to that? Someone that says, hey, when you adjust someone, well, how come there's research saying that it does opposite things?
When I work on the cervical spine, especially when you mobilize all soft tissue, there's a parasympathetic response to that. The patient relaxes. Normally, there's a relaxation tone. You do suboccipital inhibition, and the person's going to chill out. You crack someone's lumbar spine, and okay, yeah, there's almost like let's go and do something type thing. My argument to that is if there is a theoretical chance that you can stimulate both systems, then there's a theoretical chance you can hyperstimulate the patient, which means more manipulation is not necessarily a better treatment outcome. Therefore, if I could theoretically activate the parasympathetic with the neck and the sympathetic with the lumbars, why the fuck am I going to crack both at the same time in one session? Yeah. Stick to one area, do it, leave it alone until you see how the patient responds. Now, everyone responds slightly differently to treatment. So for me, I'm a big fan of less is more. I wouldn't crack someone's neck, thoracic and lumbar in one appointment because I believe there's a theoretical risk of hyperstimulation. So that's my thought process on it in terms of why I would or would not use that type of technique.
I just thought that was an interesting question because someone asked me about it and I gave them my 2 cents, but I was like, no.
What was your 2 cents?
Very similar. I said, in terms of Gonstead, he has documented throughout chapters and throughout a lot of the stuff he's done before a lot of this was even well researched, that adjusting certain parts of the spine would have a certain response. And so if you came in and you were, having sympathetic issues or parasympathetic issues, he would adjust the corresponding level based on where those fibers exit throughout the spine. And that's a real manual way of thinking about it. It's a real way, so I don't quite buy that. But when I did my thesis, I did go into the HPA axis and how that influences cortisol, and cortisol being anti-inflammatory and having an impact on the sympathetic system and parasympathetic system. And then there's a mechanism of which norepinephrine and adrenaline is released as well. And then there's another mechanism of which serotonin is released and EOs, endorphins. So there were multiple mechanisms, but obviously you have a fantastic graph, what would it be, like an image of the spine. And that's what heavily influenced my one. The difference is yours is very evidence-based. Mine was more based on like various hypotheses. And for example, I talk about the John Gostrick's method of the dentate tension. And that's one way of describing what you were talking about before, where someone comes in with back pain and a chiro will say, hey, I'm going to adjust the neck and the back's going to get better, which this does happen. And one way of them explaining that is the dentate ligament tension theory, right? Because if you're alleviating tension superior on the inferior part of the spine, it may affect the other one. I just use that as an example because, the Williams axis for me was not, this is everything it is. This is everything we've got. This is the research we've got, what it could be. And so a lot of those mechanisms, I don't necessarily think are probably 100% accurate, but they're just ways that people have tried to explain them before.
A lot of this is there's lots of different theoretical bases, and I think it's really important to have an understanding as to what some of the thought processes are. And the big thing for us is that's why we do the research, is to keep pushing out what we can really genuinely say. At the moment, we think it can do this, this, and this, but it may be able to do that, that, and that. I look at manipulation more when I look at parasympathetic or sympathetic reactions, I'm looking at it more from a treatment perspective on how the patient's going to come out of the treatment. Am I going to basically control or delete the patient by cracking them from head to foot, which is what I've done many, many times. So when I graduated from uni, you came and saw me, I'd crack you from the OA to the hallux. And you'd either feel great, or you'd go away and say, it took me 3 days to recover. I felt like I'd been hit by a bus, and that 30-minute appointment, I don't know what on earth happened. It was literally a 50-50. moving forwards, when we started looking at the research and we looking at these possibilities, we started to bring the treatment down, less technique, less intervention. So now when someone comes in, I actually get much more consistently better results by doing less. And I'm a massive fan of only doing what I need to get the results that I'm trying to get. More cracking doesn't mean a better therapeutic outcome. More cracking just means there's a higher chance of you almost control alt deleting the central nervous system and the patient basically going, and having to recover for a week. So I look at it more I try and teach it from a simplistic basis. Do what you need to do and no more.
The minimal effective dose is a fantastic way, to apply, especially with that theory. You know how when you're at osteo school, like you'd be practicing on each other and you'd get to the end of semester and everyone's a little bit wasted. At our school, the teachers used to say to us near the end of semester, stop practicing on each other's necks, stop adjusting each other because you guys are everyone's so over adjusted and everyone's getting super nervous system fatigued. And did you have that, Stephen?
Some people did.
But I just thought it was always an interesting thing. Like
we always said it's 5 years to graduate, 5 years to recover. Because 5 years of being absolutely brutalized by classmates who can't crack the toffee and sort of leave osteopathy school absolutely in pieces because of all this really overly aggressive technique. Your body's just absolutely shot. I'm sure half of my underlying back issues I had was because of the degree program, probably.
Yeah. Well, I was always someone that people wanted to adjust because people wanted to have, a lot of the people in my program wanted to be sports cars. And what that means is you adjust them and then you put some tape on them and then you're a fucking sports car.
We do a free course on that. Just chucking it out there.
Exactly. So it is a very good one. But they can't assess movement, biomechanics, anything along those lines. But as long as you can tape, you can be a sports car. And what they would want is experience adjusting a heavyweight powerlifter. Like I was at the time, I was the strongest squatter in my country and I was a world-class powerlifter and they wanted to get me down. So I was face down on the bloody tables a lot in technique class. And not only would it be the students, but teachers would come over and have a crack, have a bloody, jump on me to stimulate and to feel good about their ego. It was one of those things where I was just always face down. I was getting side postures. My neck was getting adjusted. So I got very sick of it. I got very, very sick of it. And I would go to the center and my neck would get adjusted all the time because I've got a little bit of anterior to C2. It's not anything significant, but a chiro would look at it and they would draw their lines up and they would freak out. And so I got pulled into the side room. Pretty much I've got a little bit of a lack of lordosis and my C2 is a little anterior, but it's nothing crazy. And I got pulled into the side room. I felt like I had cancer the way that my teacher was talking to me. Like I literally thought my neck, I said, what happens if I don't fix it? Like, is my head going to slip off my neck? Because at the time I was scared. I was like, oh my gosh. And so I took my x-rays and I messaged a bunch of people, Dr. Woodbury, we were talking about before, and a bunch of chiros in the industry. And I said, what's going on? And pretty much everyone responded to me, it's a load of crap, your neck's fine. And what happened is they were adjusting my neck P to A primarily and it had already been anterior. I was walking out of the chiro center, migraines extremely worse, dizzy, feeling sick. Just these neck adjustments were not what I needed. I tell them and they just wouldn't take it on. And it wasn't until it was 2 years of that until mid-year around my second year they figured out that my C2 was a little forward and we probably shouldn't be adjusting yet. P-Day. Anyway, I want to let you go. We've had such a great conversation. Thank you so much for coming on. It would be amazing at some point to have you back on. Sometimes what we do is we have people on together that we think will constructively create a conversation. And I have a feeling that you would be really fantastic with Dr. Andre, Stephen.
I was thinking that.
But he is amazing. He's a pro athlete, all-time track and field American star, and he's also a fantastic chiropractor. So you guys would be cool. But anyway, I always say to my guests,
definitely, man,
great to have you back on. Thank you so much for your time. We really do appreciate it. We try to go short, but you know what happens is that when you get a good person on and you have a good podcast, it goes long. That's life. Anything else you want to say, Steve?
Just thank you so much for joining us. I know it's late your time.
Yeah, we really appreciate it. Hopefully we can do this again sometime soon.
Sounds like a plan, man. All right, listen, take care, guys. See you soon.
Cheers, mate. Have a good night. See you, Steve.